morning, everyone, and welcome to today's Public Health Ontario microbiome rounds on a review of the current global Mpox situation and the public health approach to the increase in cases in Ontario. My name is Hamida Megani. I am the Deputy Chief Medical and System Support here at Public Health Ontario, and I have the pleasure of moderating today's session. Before we begin, I will mention a few housekeeping items. The chat pod has been disabled to limit any distractions during the presentation. Please use the Q&A pod if you have questions during the session. A discussion and question period will follow the presentation. If at any point during the session you experience any technical issues, please email capacitybuilding@oahpp.ca. I would like to state that as the moderator of this session, I have no relevant conflicts of interest. Before I introduce today's speakers, let's take a moment to acknowledge the land. This land acknowledgement is by Danielle Claire Coles. I acknowledge and respect the lands, sky, and waters of Ontario, including for their contribution and sharing to support all life within. I acknowledge and respect the treaty, unceded, and traditional territories of all First Nations across these lands and waters. I acknowledge and respect the traditional territories and communities of the Métis Nation of Ontario. I acknowledge and respect Inuit connection and contribution across these lands and waters. Please join me in acknowledgement and respect of all Indigenous peoples, our life journeys, our worldviews, and our indigeneity. May we respect and honor the many connections, relationships, and life journeys of Indigenous peoples and our indigeneity to the lands, skies, and waters across all Ontario since time immemorial to this very day. May their wisdom always guide our own paths forward with open hands, open hearts, and open minds for the mutual success and benefit of all in Ontario. It is now my pleasure to introduce the speakers for today's presentation, Dr. Austin Zygmunt and Dr. Christine Navarro. Dr. Austin Zygmunt is a public health physician at Public Health Ontario. His portfolios include sexually transmitted and blood-borne infections, emerging infectious disease threats, including Mpox and viral hemorrhagic fevers, environmentally acquired infections, and infection prevention and control lapses. He is a fellow of the Royal College of Physicians and Surgeons of Canada, specializing in public health and preventive medicine, and an assistant professor with the Department of Family Medicine at the University of Ottawa. His public health interests include communicable diseases, health equity, and LGBTQ+ health. Dr. Christine Navarro is a public health physician at Public Health Ontario. She supports the Immunization and Vaccine Preventable Diseases team, as well as the Enterix team. Before joining PHO, Christine worked as an Associate Medical Officer of Health at Toronto Public Health. Christine is a Fellow of the Royal College of Physicians and Surgeons of Canada, specializing in public health and preventive medicine. Christine is also an Assistant Professor with the Dalai Lama School of Public Health at the University of Toronto. And with that, I will now pass it on to Austin.
Thank you, Hamida. Hello, everybody. I'm excited to be co-presenting with Dr. Navarro today on the current global Mpox situation, as well as the increase in cases we've seen here in Ontario. This is one of our standard disclaimer slides here at PHO. And in terms of disclosures, I do want to note that I am a volunteer board member at Max Ottawa, which is a non-governmental organization that provides health and wellness services, including for Mpox, but I do not have any other disclosures, and our other speakers have no disclosures as well. So we have three objectives for today's presentation. The first is to understand the epidemiology of Mpox in Ontario and globally, including a description of key differences between clade 1 and clade 2 infections. We will review key updates to the public health approach to Mpox in Ontario, and this includes new case and contact management guidance, an update on laboratory testing, as well as a review of infection prevention and control measures, or IPAC, in community settings. And finally, we'll describe eligibility criteria for Mpox vaccine, as well as review its effectiveness in preventing infection. So here's a high-level outline of today's presentation. We'll go through just a quick background on Mpox, review the current global situation, touch on those key points highlighted in our objectives, and we'll finish with a Q&A panel. So background on Mpox. So Mpox is an orthopox virus in the Poxviridae family, and many may be familiar with the renaming of Mpox from monkeypox, and this name of the virus has not changed, so we still call it monkeypox virus. However, in more academic circles, you may see it referred to as MPXV, and in public communications, you might see it referred to as Mpox virus, but for today's session, I'll be referring to it as MPXV. And MPXV has two distinct clades, which are classified into clade 1 and clade 2. And these have subclades named A and B, and these can be further distinguished by lineages. Both clade 1 and clade 2 are endemic to West and Central Africa. And starting with clade 2, subclade 2A is primarily seen in animals with transmission to humans and rarely human-to-human transmission. And this is the subclade that was responsible for an outbreak in the United States in 2003 due to importation of infected rodents from Africa. Subclade 2B was responsible for the global outbreak in 2022, which we'll touch on in this presentation. And then for clade 1, it's only recently been classified into two subclades. Subclade 1A represents the historical clade 1 virus, while subclade 1B represents the novel strain that has recently emerged in the Democratic Republic of Congo. In terms of transmission of the virus, there are various modes. So it includes person-to-person transmission. This can occur through close contact, which may be skin-to-skin, mouth-to-mouth contact, such as kissing, as well as sexual contact. It can also spread through respiratory droplets, such as through coughing. In Africa, it's commonly seen through animal-to-human transmission, and this can occur through bites and scratches, as well as activities like hunting or eating and food from an infected animal. And other less common routes that do exist include fomite transmission, which would be transmission from a contaminated object like clothing or bed sheets. And we've also seen examples with transmission through needles, and this includes in healthcare settings through needle stick injuries, as well as some examples from tattoo parlors being able to transmit. When we look at the characteristics of the virus, looking at the reservoir, this is the reservoir is an organism or environment that a pathogen would depend on for its survival. So for the MPXV, this is animals and most commonly rodents. The incubation period is the time from exposure to when someone's symptoms would develop. And on average, this is 7 to 10 days for Mpox, but can range from 3 to 21 days. The period of communicability is how long someone's infectious to other people. So this begins when the symptoms start, and it continues until the rash, which we'll speak about, does scab over, crests, the scabs fall off, and a new layer of skin has formed underneath. If an individual has some lesions on mucosal surfaces, like in the mouth, for example, those need to heal as well. There is some emerging evidence that some people may be infectious in the days preceding their symptom onset. So Mpox infection. The presentation is highly variable. Most commonly, Mpox involves a rash or lesions that are painful, and these can last 2 to 4 weeks and progress through various stages, as you can see on the diagram on this slide. So they go from a macular-papular phase to a vesicular pustule, and then they will scab over. These lesions might start on the face and then spread elsewhere onto the body, or they might just occur where direct contact is made, like on the mouth or in the genital area. The rash or lesions can come before other common symptoms. They can also develop after, and these common symptoms are listed here on the slide: fever, headache, chills, lymphadenopathy, which is swollen lymph nodes, and muscle aches. Certain populations are at higher risk of having severe illness with Mpox infection, and this includes individuals who are immunocompromised, pregnant individuals, and children under the age of 12. So the global outbreak, which is ongoing, first started in May of 2022. And as you may remember, individuals with Mpox were being reported from many countries that had no direct link to endemic areas in Africa. So because of this, the World Health Organization, or WHO, declared a public health emergency of international concern in July of 2022. That ended in May of last year. And through this time period, there have been over 100,000 laboratory-confirmed cases from 121 countries. So I know this graphic is hard to see, but the darker the blue, the higher the number of cases, laboratory-confirmed cases that have been reported. The vast majority of cases in this global outbreak have occurred in adult males, particularly those aged 18 to 44. And these individuals identify as gay, bisexual, or men who have sex with men, also known as GBMSM. However, there are a small proportion of cases that are female, as well as cases that are less than 18 years old. So the current global situation. So the World Health Organization declared another public health emergency of international concern due to Mpox just over a month ago on August 14th. And the reason for this declaration was several. So the first was the spread of this new novel subclade 1b, which started in the Democratic Republic of Congo, or DRC, and then spread to neighboring countries where the virus had not previously been detected. The WHO also acknowledged that there are ongoing Mpox outbreaks of other clades in Africa, which can be seen on this diagram. So the green represents outbreaks due to clade 1A, the beige is clade 1B, and the blue is clade 2. And you can see in some countries there are mixed Mpox outbreaks. In terms of spread of this novel clade 1b, we have seen it detected in 2 countries, Sweden and Thailand, as of yesterday, and these are both travel-related cases. Okay, this slide is showing an epidemiological curve of laboratory-confirmed Mpox cases in Africa through this period since 2022. And you can see more recently, the vast majority of cases are being detected in the DRC. So that's where the largest Mpox outbreak in Africa is occurring. And more recently, an increase in cases in Burundi as well. I will note that this is for laboratory confirmed cases, and there are some limitations in capacity to test all suspect cases in Africa with signs and symptoms of Mpox. So the true numbers are likely higher than what's represented in this curve. So emerging data on clade 1A and clade 1B, MPXV in Africa. When we look at subclade 1A, and again, this is the historical clade 1 Mpox, it's primarily affecting individuals less than 15 years old, so mostly children. It is being transmitted through person-to-person, non-sexual contact, as well as from animals to humans. And the areas that this is being transmitted in are really limited to where it's currently endemic, which includes rural and forested areas. From the literature, we know that clade 1 Mpox infection tends to be more severe than clade 2. When we're looking at the new subclade 1b, this is predominantly affecting individuals aged 15 years and over. It's spreading through person-to-person contact as well, but this includes sexual and non-sexual contact. We are seeing transmission occurring in urban areas, and the emergent evidence to date is suggesting that it may be more transmissible than subclade 1a. This evidence is also suggesting that the subclade 1b infections may be less severe than subclade 1a. So here's another epidemiological curve that is showing the number of cases, again, laboratory confirmed cases by World Health Organization region. And you can see a predominance of cases in the Africa region, which is driven by the large outbreak in the DRC. But when looking at top 10 countries reporting cases over the last 6 months, they really are spread out across the world. So in the Americas, this includes the United States, Brazil, and Canada. In Europe, it includes Spain, the UK, and France. And then other countries rounding out the top 10 are China, Thailand, and Australia. So the Public Health Agency of Canada has recently completed an updated risk assessment on clade 1A and clade 1B. And they've answered 4 questions, which we'll go through here. So the first is, what is the likelihood of at least one traveler infected with either of these subclades entering Canada in the next 3 months? For clade 1A, they've assessed this to be low risk, but have high uncertainty. So the first is the estimate, and the brackets is the uncertainty with their assessment. The reason PHEIC has assessed this as low is because this is predominantly being transmitted in rural and remote parts of Africa, and so the thought is that it has a less chance of being imported into Canada. That's compared to clade 1B, which is a high risk of importation because this is being transmitted in urban centers and has already demonstrated importation into other jurisdictions outside of Africa. The second question, what would be the impact on an individual infected with clade 1A or 1B Mpox? So when looking at those populations that we know have higher risk of Mpox infection, the risk would be major for those populations if there was significant spread amongst children and infants, pregnant individuals, and those who are immunocompromised. But when we look at those without known risk factors, there is an assessment that the risk would be higher for clade 1A versus 1B, and that's due to the emerging evidence that clade 1B infections are less severe than clade 1A. Okay, the third question, what is the most likely spread scenario should an infectious traveler enter Canada with either clade? And so if this was to occur, the most likely result would be transmission occurring in a household as well as to non-household close contacts, including sexual contacts. And similar to what we saw with the clade 2B global outbreak, there would be potential for domestic amplification through high contact sexual networks. And this could include among sex workers and their clients, as well as amongst the GBMSM community. Finally, what would be the population health impact on the affected and the general populations? So again, those subgroups that were identified, the households and non-household close contacts, in particular high-risk populations, would have a more moderate impact versus the general population, which has been assessed to be a minor risk. So now move on to how we test for the virus at PHO, or Public Health Ontario. And we use a polymerase chain reaction or PCR diagnostic test on appropriate specimen types. So that could be a lesion swab, and we'll go through that on the next slide. At PHO, we detect 2 viral targets for Mpox. The first is a generic target. So this would be reactive if either clade 1 or clade 2 is the virus that a person has. And then the other is a specific target that is only for clade 2 infections. So in Ontario, all of our cases have been clade 2B infections. And so common test result would be that they would be positive for both the generic and the specific target as it detects clade 2 in both of those. We do have our laboratory colleagues working closely with the National Microbiology Laboratory, or NML, to develop an assay that would be able to detect and distinguish subclade 1B. And if an individual with clade 1 was to be tested in Ontario, we would be able to identify this individual with testing. So what would happen would be that typically the generic target would be detected given that does test for clade 1, and they would be negative for that specific clade 2 target. If this situation was to happen, it would get flagged and the specimen would undergo whole genome sequencing to distinguish between clade 1A versus clade 1B, and would also be sent to the NML for confirmation. Okay, so in terms of collecting specimens, so I've listed here the 3 most common types of specimens. The 2 most common would be a lesion fluid or some crust material or an actual swab of the lesion. And if collecting these types of specimens, we recommend using a sterile tube or container or virus culture collection kit with the order number there. That's your standard virus culture collection kit. And if a patient is presenting with rectal symptoms like rectal lesions or pain, we'd recommend using that same virus swab on that area. The laboratory has done some analyses, and there is really high sensitivity of testing lesions for Mpox, which is higher than the nasopharyngeal or NP swab and throat. If testing lesions, you do not need to deroof the vesicles or use sharps to collect the fluid inside. And when looking at an NP and throat swab, again, you can use a sterile tube container, the virus culture collection kit, but can also use a respiratory collection kit. We generally don't recommend that these swabs are used if a patient has skin lesions that can be swabbed. This is more for a patient who might be in their prodromal phase with respiratory symptoms. And if using the specimen type, we recommend doing a blood sample as well. So to transport the specimen, there's some typical processes that need to be followed. So as always, label the specimen with the patient's name, the date it was collected, and other unique identifiers such as their date of birth and health card number. You need to place the specimen container in a biohazard bag with their completed general test requisition for monkeypox virus testing. But with these specimens, they have been classified as Category B by Transport Canada for land and air. So the package has to have this label that you can see on the slide where it marks temporary certificate TU0886. And so this is an example of what could be printed and put on the package. And then in transportation should be stored on ice packs at 2 to 8 degrees. This figure showing the number of new individuals tested for Mpox, as well as the test percent positivity by week. And you can see earlier in the year, we were testing anywhere between maybe 15 to 30 individuals per week. And through June, July, and August, that's been increasing to around 60 to 70 now. We have had high variability in the test positivity as well. Back in 2022, during the outbreak in Ontario, we used a weekly percent positivity threshold of less than 5% to indicate low levels of Mpox activity. So you can see we've had quite high percent positivity through most of the year and have not had sustained low levels for a number of months. Okay, we'll go into Mpox epidemiology here in Ontario. So this figure is showing the number of laboratory confirmed Mpox cases by week in Ontario since January 1st with data up to September 7th. And in this time period, we've had a total of 184 cases. You can see the increase in Mpox in Ontario began in late January with a greater increase through June and July. And although you're seeing some lower numbers more recently in the last weeks of August and September, I will note that it does take time for individuals with Mpox to present to healthcare, to get tested, and then for that data to be entered into our surveillance system. So in subsequent reports that we publish on our website, you might see increases in the number of cases for these weeks. Again, all Mpox cases in Ontario are clade 2B, and we've had no cases of the new clade 1B detected in Ontario. In terms of key highlights of the cases this year, we've not seen any significant change from the known epidemiology of Mpox in Ontario. So vast majority of cases continue to be adult males who identify as having sex with same sex. We have had a few cases in females. Most of these have a known risk factor or a link to a known case. Most of our cases are occurring in the Greater Toronto area, so just over 92%, and in total, 11 health units have reported at least one case this year. In terms of disease severity, we are not seeing any significant disease severities. Only 2 of 184, or just over 1% of cases were hospitalized, and no deaths have been reported. The most frequently reported risk factors are similar as they've been through the entire outbreak. And so that includes engaging in sexual or intimate contact with a partner of the same sex, having a new and or more than one sexual partner, or having an anonymous sexual partner. When looking at the travel history, the vast majority of cases, 85% of them, are reporting no travel during their incubation period, so that time when they could have gotten their infection. And this suggests that most of the cases in Ontario are due to ongoing local transmission. And here we are, so I'll hand it over to you, Christine, to talk about Mpox vaccine.
Thanks, Austin. And I will be talking about the Mpox vaccine that's available here in Canada. But before that, there were earlier generations of smallpox vaccine that were highly effective. But because they were made from a live replicating vaccinia virus, they were also associated with a number of adverse events following immunization, including some serious outcomes from keratitis to disseminated vaccinia. So even though these vaccines were effective and were really instrumental in the eradication of smallpox, since that time, there has been a search for effective vaccines that are safer for use. The modified vaccinia Ankara Bavarian Nordic, or MVNA-BN, known here in Canada as Imvamune, is one of those third-generation vaccines, and it has been altered such that it no longer replicates in the human body. It's administered at 2 doses subcutaneously at a 28-day minimum interval. It has actually been around for quite a long time in Canada and authorized first by Health Canada in 2013 for use in emergency situations against smallpox infection for adults. And in 2020, that authorization was expanded to include other orthopox virus infections, again, in adults at high risk for exposure. And that really was alluding to individuals who work in a laboratory, a specialized laboratory, or reference laboratory. With the emergence of the Mpox outbreak in 2022, by that time there was very limited evidence on the clinical use of the Mpox vaccine, MVNA-BN, against Mpox infection. However, jurisdictions needed to act quickly given the rapid spread of the infection. So in Ontario, we implemented a post-exposure program for contacts of cases, which Austin will be mentioning a bit later. That was implemented in May of 2022. And in mid-June of 2022, we implemented a pre-exposure program in Ontario that focused on those individuals that were at highest risk of coming into contact with with a person with Mpox. And as per the epidemiology, this was really focusing on the GB-MSM community, individuals who had additional risk factors like having more than one partner, confirmed sexually transmitted infection in the last year, attending venues for sexual contact, and anonymous sex. Any of their sexual partners, of those individuals who met those criteria, and a sex worker regardless of their gender, sex assigned at birth, or sexual orientation, and any persons who engaged with a sex worker. Staff or volunteers in sex on-premise venues were also included in the eligibility criterion because of their risk of coming into contact with contaminated fomite at the workplace. Now, these criteria shown here are as of June 26, and with that update, there was the addition of individuals who engage in sex tourism, and that's regardless of gender, sex assigned at birth, or sexual orientation. And this is aligned with the National Advisory Committee on Immunization's interim statement issued in May of 2024. So vaccine can also be considered for individuals who anticipate experiencing any of the above scenarios, as well as household and sexual contacts of those identified above who may be at greater risk of severe illness, including persons who are immunocompromised or pregnant. And then, of course, we have the research laboratory employees who are working directly with the Mpox virus. This graph, which shows the uptake of vaccine, the number of vaccine doses administered here in Ontario, and with the cooperation of public health units, a number of community agencies, Gay Men's Sexual Health Alliance, and the Ministry of Health, there was really excellent uptake during that 2022 between June and September. Altogether, we've had 40,888 persons receiving one dose of vaccine. And then with the rollout of the second dose becoming available on September 30th, that's shown in the orange bars there. Unfortunately, the uptake has not been as good. So only about 36% of vaccine recipients have received a complete 2-dose series. So we really want to emphasize the importance of getting that second dose. And evidence in the literature on the effectiveness of Mpox vaccines against Mpox infection. So this is a image from the recent National Advisory Committee on Immunization interim statement, which summarizes some of the data that's emerged since the rollout of the pre-exposure programs in various jurisdictions. And you can see here in the top panel, a single dose of vaccine is around about 36 to 86% effective in these various studies. And here in Ontario, which is the second from the top, we had a vaccine effectiveness of around 59%. There were a few studies that showed vaccine effectiveness following 2 doses that was higher than a single dose, closer to sort of that 80-85% effectiveness. And in addition to these studies, there's also been some evidence demonstrating that there's the Imvamune vaccine is effective against hospitalization and reducing the risk of hospitalization, as well as reducing the severity of symptoms. So finally, I just want to bring people's attention to the updated smallpox and Mpox vaccine chapter in the Canadian Immunization Guide. And this integrates that information from their interim statement in May of 2024. So again, individuals at high risk of Mpox should receive 2 doses of the vaccine at least 28 days apart. And if a person has received only 1 dose, they really should get that second dose for more complete protection, regardless of how long it's been since that first dose. Mpox vaccine can be given concurrently or at any time before or after any other vaccines. And at this time, there aren't any recommendations for additional doses of Mpox vaccine beyond that complete series for individuals at high risk in community settings, including immunocompromised populations. And so I will turn it back to Austin for the rest of the presentation.
Thanks, Christine. So I'll now go through case and contact management guidance for Mpox. And there is new guidance that is being released from the Ministry of Health this week, which we will be touching on today. So the first thing to note here is when public health units should be providing notification of an atypical Mpox case to PHO and the Ministry of Health. And so one would be if there's a suspicion that a case may be infected with clade 1 Mpox. And this could be based on travel history, risk factors, or laboratory results. And the recommendation is to proceed with case and contact management as usual. And then the second atypical cases would be a case that does not identify as part of a key population that is known to be affected here in Ontario, or doesn't have a known risk factor. So this includes individuals who identify as male but report sex with an opposite sex, identify as female, as well as those under the age of 18 years, excluding an adolescent with a known risk factor. And the reason we want to be notified of these cases is to monitor for changes in Mpox transmission dynamics here in Ontario. And so when we're looking at the goals of case management, the aim of this new guidance is to balance the risk of transmission of the virus to other people while taking into consideration the impacts of a prolonged isolation period on an individual. We do know, as we chatted about earlier in the presentation, that there is a wide variability in how Mpox presents. And so this new guidance allows public health units to tailor their case management approach based on the case's signs and symptoms, as well as their ability to apply risk mitigation measures. So with this new guidance, self-isolation is not going to be generally required if a case can adhere to a risk mitigation plan. So this would include things such as performing frequent hand hygiene, being able to cover their skin lesions with bandages or clothing. They should wear a medical mask if they have oropharyngeal lesions. So those are lesions in the mouth and throat or respiratory symptoms. They should avoid interactions where prolonged close contact, such as direct skin-to-skin contact, can occur, and that would be avoiding sexual contact as well. The individual should avoid, or the case should avoid direct contact with individuals at higher risk of disease. So again, those are children less than 12 years old, pregnant individuals, and those who are immunocompromised. And finally, they should avoid congregate settings if possible. Is a few scenarios where it's going to be required. So if a case has skin lesions that cannot be covered, or if they have systemic symptoms that make it difficult to adhere to the risk mitigation measures, then they would be asked to self-isolate. So an example of this would be a case that has lesions in their mouth and they're coughing, but they're unable to wear a medical mask when they're around other people. Another note to this is that a case who presents with mild symptoms but develops symptoms that make adhering to risk mitigation measures later on would have to enter self-isolation. So this might be someone who starts with one skin lesions and then develops numerous lesions that can't be covered. There is existing recommendations around recommendations to take with animals and pets. And due to time, I will leave that for review as it's the same as previous guidance. In terms of contact management, when we're looking at an exposure risk assessment, the case symptoms are important to be considering. So thinking of the location and extent of the lesions, have the lesions been appropriately and consistently covered? And do they have other symptoms such as respiratory symptoms? And we're using a measure such as a well-fitting mask. When thinking of contact characteristics, you want to know, particularly if they were at higher risk of developing severe disease, those individuals are listed there again. And then you want to consider what the nature of the interaction between the case and contact was. New in this guidance as well is considering extending of the contact tracing period. So as noted, a case may be infectious up to 4 days before the onset of symptoms, although we don't know what proportion of these individuals are actually able to transmit the virus. So if a health unit is considering a more aggressive approach to their contact management, you could consider using this extended contact tracing period. So this is the exposure assessment table that will be in the guidance. Provides 3 categories of risk: high, intermediate, and low. And some updates to this have been clarifying some of the examples that have been commonly seen by health units. So a high risk would really be coming into direct contact with a case. Examples of this would be an intimate or sexual contact, or perhaps touching a lesion without wearing gloves. Some examples of intermediate risks would be having unprotected face-to-face contact and not wearing a medical mask, or perhaps coming in contact with some contaminated items like bedding. And then low risk is listed there as just being in the room and near a case. Generally, no public health follow-up is required for low-risk contacts. In terms of contact management, quarantine is not indicated, and asymptomatic contacts should generally be able to continue their activities. We do recommend monitoring for signs and symptoms for 21 days from last exposure. Those symptoms are listed there. If contact was to develop signs and symptoms, they should notify their public health unit and seek a clinical assessment for testing. And they should also be educated that if they've received a previous Mpox vaccine, 1 or 2 doses, that they can still develop Mpox infection. The illness may just be more mild. And post-exposure prophylaxis vaccine should be offered if it's indicated. And for that, it's indicated for high-risk contacts, offered ideally within 4 days of exposure, but up to 14 days. And if it's an intermediate risk contact, that's really a case-by-case basis based on the health unit's risk assessment. And I'll go quickly into Mpox in educational and congregate settings. So there's going to be some standard language in the new guidance around following specific legislation, as well as needing to have a heightened exposure risk assessment given the potential for outbreaks in these settings. The actual definitions of outbreaks will not change, so it's still looking at a single case that's acquired in these facilities. But what has changed is declaring the outbreak over. So looking at the 21-day period of no new cases, this is decreased from 42 days, which was 2 maximum incubation periods. It has now gone down to 1. So it's now 11:45. We've run out of time for the IPAC in community settings. This guidance is very similar to what was already existing, and this was just going to be a refresher. So the slides will be available to review IPAC for an Mpox case, for a caregiver, and then for other advice such as doing laundry and collecting waste. So I'll hand it over to Hamida for the Q&A.
Thanks so much, Austin and Christine, for the excellent presentation. So we'll now move on to the Q&A segment of this session. And we do have, in order to assist us in answering questions, we are joined now by Dr. Daniel Warshawski from the Office of the Chief Medical Officer for Health, Dr. Michelle Science from PHO's IPAC team, and Dr. Aman Hasso from PHOL. Please continue to enter your questions into the Q&A pod if you have not already had the opportunity to do so. So I have been keeping track of some of the questions in the chat box, and we'll start with the first few. These are for you, Austin. So is Mpox categorized as an STBBI, even considering non-sexual transmission?
It's a common question that we get. I think what's important here is knowing that there's multiple routes of transmission for MPXVs. So certainly in Canada, our experience has been most cases are acquiring their infection through sexual contact. But as noted, there are other routes of transmission, such as from animal to humans, as well as direct contact, including non-sexual contact. So it's not exclusively a sexually transmitted and bloodborne infection, but can be transmitted through sexual contact.
Thanks, Austin. So the next question is also for you. Do we know why Mpox affecting the GB-MSM population is more predominantly than the heterosexual population?
Yeah, so with the global outbreak, so that was due to Mpox virus clade 2B that predominantly affected the GB-MSM population, and that particular lineage that caused the outbreak had a mutation that just made it more susceptible to sexual transmission. This particular subgroup was affected due to a small population with a high sexual network. When we look at other Mpox outbreaks, including those in Africa, we do see outbreaks amongst heterosexual populations as well. So it's not a virus that's exclusively affecting GB-MSM, but in Canada has shown predominance to that subgroup.
And before I move on to another individual on our panel, a related question, do we know the severity of clade 1B compared to clade 2B?
So this is an area, again, of emerging evidence as we learn more about the novel clade 1b of Mpox. We do know historically that clade 1 Mpox infections tend to be more severe than clade 2 infections. So it's possible that clade 1b will be more severe than clade 2b, but that type of head-to-head comparison has not been done yet.
Thanks so much, Austin. So I'll now move on to a couple of questions that I think are could be appropriately answered by Daniel Warshawski. So Daniel, I think you're on the line. Thank you. Would you recommend that those who are traveling to rural parts of Africa to, for example, to work with children, get vaccinated for Mpox prior to travel? And I think there's a similar question on vaccine eligibility is related to testing being, for those healthcare workers working in places like sexual health clinics where testing is being completed for Mpox, could those be on the eligibility list for vaccine?
Yeah, thanks, Amita. Great question. I know we've been getting this quite a bit lately. So at this time, the eligibility criteria is not including travelers to high-risk areas for vaccine availability in Ontario. This is in keeping with what we've seen coming down from PHEIC in terms of updated risk assessments. And so we aren't changing it yet. Obviously, we're strongly recommending anybody who meets the current eligibility criteria and traveling absolutely does receive a vaccine. And that does include sex tourism as one of the forms of travels as well. We're continuing to review the ongoing evidence with our Mpox advisory group that we have, as well as following up with PHO and the federal government about any recommendations specifically for travelers or healthcare workers. At this time, and Austin's already gone over the IPAC recommendations very well, the IPAC works extremely well in terms of protecting healthcare workers. And so we're quite confident in that being the #1 measure that should be used to protect healthcare workers. If we see any change, it's something that we update in the future, but at this time, not expanding to those other groups.
Thanks so much, Daniel. So the next question we have, Austin, back to you. Were there any situations or events that can explain the peaks seen in Ontario over the past year?
So it's possible. A lot of this is hypothesized, but with some of the peaks seen through the summer, it's possible that it may be linked to Pride events such as Toronto Pride, which happened towards the end of June, and then we saw ongoing increase in cases in July and August. I will note that the steady increase was beginning prior to the end of June, so that may have just amplified some of the increase. But as noted, we've had ongoing local transmission of Mpox in Ontario since the outbreak was declared over in December of 2022. And so most of this appears to be local transmission and not due to imported cases from other jurisdictions.
Thanks, Austin. Okay, so another one for you. You're in the hot seat today. How long does it take to recover generally from Mpox? And after recovery, can someone be reinfected with the Mpox virus?
Yeah, so it's going to be dependent on the individual in terms of the length of time to recover. If they have less severe symptoms, maybe just like one lesion, that might take a shorter period of time than someone with numerous lesions. But on average, it does take around 2 to 4 weeks for the Mpox rash or lesions to go through their various stages and heal. In terms of reinfection, this can occur. There are case reports in the literature of reinfections being documented, so through lab confirmation, but it is incredibly rare. To date, we are still learning a lot about Mpox here in Canada, as it's fairly new to us, so it's something that is an area of active research and monitoring.
Thanks so much, Austin. Christine, I'll move over to you. Someone wants to know about vaccination during pregnancy with Mpox and whether that's safe, and you can comment on that.
It's a good question, and there hasn't been any clinical trials per se, which include pregnant individuals. There has been some limited data on individuals who are pregnant who have received the vaccine that suggests that it is safe to receive in pregnancy. And we do that is credible given that it's a non-replicating virus that's used in the vaccine. So individuals who meet high-risk criteria and are pregnant should speak to their healthcare provider and are likely to be recommended to receive it.
And another vaccine-related question, Christine. So does a history of receiving smallpox vaccine in the past provide any protection against Mpox?
So individuals who've received smallpox vaccine in the past, so in Canada, that would have been until about 1972 that it was part of routine programs. So those individuals are still recommended to receive Mpox vaccine now, even if it's likely or known that they'd received smallpox vaccine. There is a possibility that it could provide a boosting effect, but there is no reason for them to not receive the vaccine with this current generation.
Thanks, Christine. So I'll move over to some questions related to cases again. Someone's asking if there have been any cases of Mpox in women or children in Canada.
So we have had cases amongst individuals who identify as female here in Ontario. It's a very small number of individuals, and they tend to have a known risk factor or a link to a case. In terms of children, children per se, no, we have had some individuals less than 18 years of age who are adolescents with an identified risk factor, but we've had no cases amongst non-adolescents here in Ontario.
And then a question about waste management. How should the PPE used when testing a potential case, for example, in a sexual health clinic, be discarded? Is the PPE considered hazardous waste? I'm wondering if, Michelle, if you have any thoughts on this one.
Yeah, sorry. Yeah, so the waste, it should be considered infectious waste, so handled as potential infectious waste in those settings as well.
Maybe just add to that, as I didn't quite get to it on my last slide, but with the waste, so if it's like a bandage or gauze, you should be directly putting that into a dedicated waste container, performing your hand hygiene, and then double bagging the waste using strong bags.
Thanks, Austin. Always reminding everyone about hand hygiene being important for any patient or clinical encounter. Okay, and then we have another one from a vaccination perspective. Would it not make sense to ask travelers if they may have sexual contact in endemic areas? Could this help prevent importation of a case? I don't know who wants to take this one on.
Yeah, I guess so. I'm not sure that's asking about a returning traveler or someone who plans on traveling.
Yeah.
But in either case, yes, absolutely. That's something I would ask for sure. Again, like if they are going to be traveling, engaging in sex tourism or having sexual contacts, they're eligible for vaccine and should be getting it prior to travel. You know, obviously it could be a sensitive question, so it's going to depend off on the provider's familiarity with that patient, but it's something absolutely to ask about. And certainly for any returning travelers who might be displaying symptoms, we certainly want to ask whether or not they had actual sexual contacts in an area like that. I don't know if Christine wants to add anything.
That's great. Thanks, Daniel.
Always good to see everyone having the same response. Okay, so we do not have any other open questions in the Q&A, surprisingly, and we are almost at time. I'll give it about 15 seconds to see if any more questions come through. Otherwise, we will start our wrap-up period. Oh, we just had a question come through. What is the risk of infection in domestic animals? Austin, I don't know if you can respond to that one.
Sure, I can respond to that. And in the ministry guidance, there is information on recommendations for cases in how they handle encounters with animals and pets. And really the purpose of that guidance is to help prevent establishing an animal reservoir here in Canada, which we don't currently have, but is obviously common in Africa with animal to human transmission. So there'll be different guidance for symptomatic Mpox case, really trying to avoid close and prolonged unprotected contact with pets. So if you're sick with Mpox, don't snuggle with your dog or kiss your dog or sleep with your dog as examples. If the animal is symptomatic, there's going to be some guidance on consulting with a veterinarian to seek advice on testing and keeping the animal away from other animals.
Thanks, Austin. And a final question, and either you or Daniel could answer this. I'm not clear on the exact response. In community public health clinics in Toronto, are the PH clinics performing testing, or only currently is that happening in hospital or lab settings? I believe there are clinics doing diagnostic testing.
I think
I'm just looking.
The question might be around who's doing the actual test. And so that would be
Yes,
a clinician at like
administering the
your
test.
family doctor's office or sexual health clinic. And then in terms of who's assessing the test after it's been collected, that's mostly done at Public Health Ontario, but there are other sites in Ontario that are testing those specimens for the virus.
Well, thanks so much for answering all of our questions. Thank you so much to the panel. And as we wrap up today's rounds, I would like to not only thank the speakers, but also for all of you who joined us for today's webinar. You can expect to receive a brief and anonymous Public Health Ontario Rounds survey for today's session. Please try to complete this to help us improve our programming. Please note that due to technical issues today, we're unable to provide our usual CME letters. We hope to provide them in the near future, and thank you for your patience. Lastly, to access past PHO presentations and to view confirmed and upcoming sessions, please visit the PHO website, head to Education and Events, and click on Presentations. Thank you so much and have a wonderful day.